So welcome to everybody to this European School of Urology webinar on this Tuesday afternoon or evening rather. The title of the webinar is Imaging and PSA Assessment in Non-Metastatic Castrate-Resistant Prostate Cancer Patients and the Treatment Consequences. We have chosen this webinar because obviously in the recent years we are not stopping to change paradigms in prostate cancer management. Just a few days ago at ASCO there were another paradigms that were changed based on recent publications. We might go into a short discussion at the end of this webinar with this regards. And another paradigm that was changed is the management of non-metastatic castrate-resistant prostate cancer a few years ago. And since the publication of this data, we are still struggling with the right indications, the use of imaging, the use of PSA, how to select therefore the patients for this treatment and how to follow and treat them and when to change treatment. And these are the burning questions we would like to answer during this webinar. And we have two excellent experts in this webinar as faculty. It's Bertrand Tombal from Saint-Luc in Brussels and in Belgium. And we have Thomas Stoiber from the Martini Clinic in Germany. Both are known experts in the field of the treatment of advanced prostate cancer. And the first talk will be given by Thomas Stoiber, and he will address the question about the optimal PSA and image assessment in non-metastatic castrate-resistant prostate cancer and the consequences to take out of the PSA and imaging information. Thomas, please, very pleased to have you here, and the floor is yours. And just 1 second, do not forget to answer the question, to ask your questions via the Q&A platform that you have inside of the Zoom program. And we will answer those questions after each of the talks. And feel free to get involved here, and we would be happy to have your feedback. So Thomas, the floor is yours. Thank you very much.
Thank you, Jochen, for this kind invitation and introduction. Dear colleagues, dear Professor Tombal. So I jump right into the field for the sake of time. We may expect an exciting soccer game down the road, the end of the day. So I will talk about the disease non-metastatic CRPC and how to risk stratify the patients. These are my disclosures. And I start my presentation with a case discussion. And I want to discuss a 68-year-old man with an intermediate unfavorable risk prostate cancer, lesions 4+3, and an initial PSA of 9 nanogram per milliliter. And he decides to undergo EBRT without ADT. So we can here see the PSA curves that goes nicely down under radiation or as the result of radiation. But within a year, it goes up again, up to 4, which is 2 nanogram per milliliter above the nadir. So this is the BCR criteria were met for biochemical recurrence following radiation. So the patient defers any workup for salvage treatment, and leprolin as an ADT was started. So he goes nicely down with the PSA again and nicely down with the testosterone level. But 2 years or 1.5 years down the road, PSA goes up again to 3.6, while the testosterone being under castration. So this patient has a rising PSA being under castration. And why is the consideration of the PSA so important? That's because there is a strong correlation between the PSA doubling time and the risk to develop metastasis. And this has been shown by several trials with the relationship. There's with a decrease in PSA doubling time below 10, the risk to develop metastasis increases dramatically. So that's why the cutoff of 10 has been chosen based on trials. For example, a trial that evaluated denosumab in nmCRPC patients to prevent metastasis. So based on this relationship, the PSA doubling time is crucial to risk stratify patients in a high risk to develop metastasis and a low risk to develop metastasis. How can you calculate the PSA doubling time? I mean, if you're a genius, you can do a mental calculation, but I would recommend, since it's a complicated algorithm, to go for web-based nomograms. For example, the MSKCC nomogram, where you can easily add your PSA values over time, and then you calculate, and then you get a list of PSA doubling time, slope, velocity. You can print it and you can hand it to the patient. And in this case, we have a PSA doubling time of 2.8 months in this example. So what are other clinical scenarios for non-metastatic CRPC? This is the clinical scenario we just described. So biochemical progression after radiation plus ADT, or for a biochemical recurrence after radiation. So if he develops castration resistance, this is one of the scenarios. Another would be adjuvant ADT or the treatment of a BCR following radical prostatectomy plus minor radiation. And another clinical scenario would be ADT is a sole treatment for locally advanced tumors that are not suitable for local treatment, or where the patient refers a local treatment. So this is another scenario where nmCRPC may occur. So the keynotes for PSA and non-metastatic CRPC is that men with a rising PSA under castration with a PSA doubling time below 10 months have a significant risk to develop metastasis. Vet-based nomograms are helpful for PSA doubling time calculation. A PSA increase under ADT is typical for men after EBRT in context with ADT or ADT alone for unresectable tumors, or ADT for BCA after radical prostatectomy. And then an imaging assessment should follow. So that's the next topic. What imaging should we choose? And here we have the problem that if you order a molecular imaging in terms of a PSMA PET scan, you may trouble with situations. So here you have the local recurrence after radiation therapy. And here you see on the conventional scan, a CT scan, no osteosclerotic lesion, so no evidence of metastasis. But in PSMA PET scan, in the molecular imaging, in M1 disease, the evidence for bone metastasis. So what is right and what is wrong, and what should we risk stratify for further treatment? And this publication shows the whole dilemma. It's a multi-center evaluation of men that meet the criteria for high-risk patients that have, so non-metastatic CRPC patients that have a high risk to develop metastasis. And 200 patients were identified where conventional and PSMA PET scan was available. So both imaging modalities were compared. And as a result, you can see that among these patients, that they were all defined M0 according to conventional imaging. You may find up to 55% M1 disease based on PSMA PET scan, with up to 39% with distant lymph node metastasis, up to 24% bone metastatic disease, and even up to 6% visceral disease. So this is the conflict now that we have on the one hand side an M0 situation, but if you add the molecular imaging information, you have an M1 disease. There's no real solution how to handle this. The experts say it is critical that the clinical relevance of identifying metastatic lesions by PET scan or whole body MRI not detectable by CT and bone scan undergoes proper scrutiny in the clinical trials, so that these new imaging modalities are clinically qualified to guide clinical decisions. So far, we don't know how to handle the PET scan in this context. What about clinical N1 disease? So N1 disease and imaging, like in lymph node metastasis in the iliac vessels or in the pararectal space, are considered N1 but not M1, so they are still M0 and may be considered for non-metastatic CRPC treatment. So, and it was permitted in the trials. So in conclusion, for imaging, clinical N1 disease but M0 disease stage are allowed for nmCRPC imaging treatment. Do not order a PSMA PET scan for CRPC disease because this is not recommended in the guidelines, and you may run into the conflict of deciding, is it M1 or is it M0? You may have an underestimation in the bone scan, in the PET scan, a false positive rate of M1 disease. It is uncertain, and the data for non-metastatic CRPC-based trials are included by patients with conventional imaging alone. So no PET scan was allowed in the clinical trials. So let's go back to our clinical case. Now we have this guy after radiation and castration with a PSA increase with a doubling time of 8 months with a high risk developed metastasis because the doubling time is 8 months and he has no evidence of metastasis on conventional imaging. What should we offer such a patient? Let's go to the non-metastatic CRPC treatment options, and we go straight into the clinical trials which led to the approval of apalutamide, enzalutamide, and darolutamide. I'm using one graphic for all the 3 trials because they were in the design, they were identical, and they were including patients with non-metastatic CRPC with an increasing PSA despite testosterone into castration. The PSA up to 2 and a PSA doubling time below 10 months, they were included in 2-to-1 randomized into placebo or apalutamide in the Spartan trial, enzalutamide in the Prosper trial, or darolutamide in the Aramis trial. The primary endpoint of all the 3 trials was metastasis-free survival, and all the secondary endpoints are listed below. Let's go to the results. And already in 2019, all the 3 drugs got approval because they met the primary endpoint of metastasis-free survival with highly significance. In the Spartan trial, apalutamide reduced the use to develop metastasis up to 72% versus placebo. The median time to metastatic progression was 40 months. And in the Prosper trial, enzalutamide gathered a pretty much similar result, and also the darolutamide in the Aramis trial, 59% reduction to risk to develop metastasis. These results were initially criticized because it was questionable whether the metastasis-free survival really translate into overall survival. And during ASCO last year, the overall survival of all the 3 trials were presented, with significance here for the apalutamide trial, Spartan, with a 22% reduction of the risk of death in favor of apalutamide, and a 27% risk reduction to die of the disease in the Prosper trial for enzalutamide, and 31% reduction for darolutamide in the Aramis trial. So now we have both significant endpoints reached, metastasis-free survival and overall survival, and similar or a list of secondary endpoints with a distinct definition in the distinct trials of time to pain progression, time to chemotherapy, time to skeletal-related events. They were all positive in the 3 trials. So based on these results, metastasis-free survival and overall survival was met. All the 3 drugs, apalutamide, darolutamide, or enzalutamide, are strongly recommended in M0 disease, so non-metastatic disease, and a high risk to develop metastasis, defined by a PSA doubling time below 10 months, to prolong metastasis and overall survival. How about the side effects? Of course, the drugs need to be taken very long, up to 40 months until progression. So we have to look at side effects, and here you can see the toxicity of special interest, which is fatigue, falls, fractures, rash, cognitive impairment, and hypertension. And here you can see, if you look at the gray bars, which are the control groups, so the control groups differ from trial to trial, so a head-to-head comparison is not possible because of different groups that were looked at. But of course, you can have a look at the delta between the control groups and the drugs, and then you can see that in context of fatigue, apalutamide and Prosper or enzalutamide need to be mentioned. Apalutamide has a distinct problem with rash and the onset of fractures. The same for enzalutamide, and also hypertension may be an issue for the apalutamide or enzalutamide application. If you look at these results in the longer follow-up consideration for the overall survival presentation at ASCO, no safety signals were seen with a longer application of the drugs. And if you look at the treatment-related discontinuation, it becomes clear that darolutamide may be quite good, acceptable for the patient, because the rate of treatment discontinuation between the darolutamide and placebo was virtually the same. In apalutamide, it was double the number, and similar in the PROSPER trial for enzalutamide. So in conclusion, apalutamide, enzalutamide, and darolutamide delay time to metastasis and prolong life of men with non-metastatic CRPC. There is a strong recommendation by current treatment guidelines, and the choice in treatment should be made based on patient preference, safety profile of the drugs, and the sequencing aspects of subsequent treatments then for M1 disease. And I'm excited that Professor Trombal will cover this topic in his next talk. So thank you for your attention.
Thank you very much, Thomas, for this very clear presentation. We have a few questions coming in from the audience. Most of them so far are going for or are with regards of imaging. And in the meantime, feel free to ask more questions if you want via the Q&A box that you have inside of the Zoom platform. So one question was asking that most of the trials that were ongoing, including Stampede, were based on conventional imaging. And if you would use PSMA PET imaging, this would be a disadvantage for these patients because you might add additional information probably to your decision making. You might get out of the box and then it's difficult to handle. What is for you the best idea or the best situation to ask indeed in this patient scenario for PET PSMA or for additional imaging over conventional imaging?
Yeah, I think that the problem arises when the patient shows up and presents with a PSMA PET scan, because then you have probably a bone lesion that would have been missed in conventional imaging. What is really helpful for me, we have a multidisciplinary board where we get demonstration of all the scans. And if you learn by doing that, looking at the scans on your own, and in every PSMA PET scan, you also have the information of the conventional CT scan, because you have the conventional CT scan and in addition the PSMA information, and then you can vote if you see a sclerotic lesion also in the native scan and also in the same spot the PSMA signal, then it's clear it's a clear M1 disease. If you have the discrepancy of M0 on the conventional part of the PET scan and M1 with a PSMA positive signal, I would go for the definition which were derived from the clinical trials. I would call them or define them being M0. But of course, this is a very academic discussion, because on the imaging report, it says there is a lesion and what to do. And now I don't know how the payers will react when you, for example, prescribe apalutamide or darolutamide, which don't have the label for M1 disease. But enzalutamide, for example, you're free to prescribe in the M1 and in the M0 space. So if you have a conflict on that, choose enzalutamide if it's available for both clinical scenarios.
Okay, very good. And you were citing the FENLA data, which looked indeed at a similar patient characteristic cohort as we had in Spartan, Aramis, and Spartan. So high risk, non-metastatic castration-resistant disease. And they found actually a positive PSMA signal in 96% of all patients, basically, and half of them were truly metastatic at distance, and the other half was rather local regional disease, lymph nodes, or local recurrence. Would this, or is this making any difference for the management afterwards, if that's truly bony disease or if it's more like a lymph node disease or maybe local recurrence? Would you still consider the treatment with ENZA, APA, or DARO, or are these those where we might consider local salvage treatments instead of a systemic treatment?
I mean, this is a really good question, because if you use the most sensitive imaging modality and you find a signal in the lymph nodes, in the pelvis, or in a prostate that has not yet been removed because the patient had a prior radiation, prior EBRT, and he's very young and very fit, of course, you could go for a very individual approach and do a local treatment in terms of salvage radical prostatectomy and extended pelvic lymph node dissection. But based on the evidence that has been derived by the clinical trials, this would be not the recommended treatment of choice. The recommended would be, of course, the systemic treatment. But since systemic is not curative, it's always palliative. It defers the progression. I would offer such a young patient who is really willing to undergo the concept also local treatment. But we need to gather data for this scenario, definitely.
Okay. And in the meantime, you will mention it already that you have different origins of castrate-resistant disease. You might have local treatment with radiotherapy. You might have had surgery beforehand. You might have no treatment at all. Does this influence in any way your decision making, or are they all the same?
I mean, as I said, if you have residual, if you still have the prostate inside because either the patient deferred local treatment upfront and got ADT alone, but now he may be motivated that he says, okay, ADT doesn't work anymore, and the tumor may be still restricted to the prostate. So yes, of course, in this scenario, or also after radiation, a local treatment could be considered. Definitely not after radical prostatectomy, where the prostate is not inside anymore. And I think then it's clear it goes for nmCRPC systemic treatment.
Okay. There's another interesting question coming in asking about those patients who have a PSA doubling time above 10 months. What are we doing with those? Are we leaving completely behind? Do we only survey them until PSA rises quicker? Or are those already also some candidates for some treatment? Are those maybe those candidates where imaging might be interesting, next generation imaging? What's your point of view on this?
Yeah, I think I would not search into deep, because then probably I would find something that would need treatment. I've showed you the curve with the relationship between the PSA doubling time and the risk to develop metastasis. And if you have somebody with a doubling time of 20 months, 24 months, 30 months, they have a very indolent course of the disease. So I would leave these patients alone. You may discuss whether you can give bicalutamide to do a little bit of PSA cosmetics, but definitely I would not go for the recommended systemic treatments, because they are restricted to a high-risk developing metastasis population. So I would go for surveillance, actually.
Very good point. Another question goes for other imaging modalities again, and that is going for PSMA PET CT or PSMA PET MR. Do you have any experience with that? Probably that's one side of the question. The other question is, how do you compare PET PSMA with whole body MRI?
Okay, this is a question which goes strictly into the super expert for imaging. I mean, we have little experience here. We only have one radiology center that offers the PSMA MRI. So I would say 99% of all the PSMA images are like CT scans. So as I remember, I read an abstract which is showing that there is no big difference between the both modalities, because the most significant is offered by the PSMA signal and not the conventional platform in behind. So basically, I can't tell you whether in PSMA MRI offers any advantage over the PSMA CT scan. I mean, the PSMA PET scan is expensive enough, and it's not at all covered by all the health insurance companies. And I would guess that a PSMA whole body MRI is even more expensive.
Correct. Another question, maybe a provocative one, said that ENSA obviously is indicated for non-metastatic and metastatic castrate-resistant disease. So is the entire discussion not obsolete, and should we not really bother and just give enzalutamide to everybody in this scenario?
It's a fair point, but I mean, we have shown, I've covered one aspect, which is the toxicity or the tolerability of the drugs. And if somebody has probably like a mental impairment already, or a neurological medical history with seizures or whatever, probably you would not go for enzalutamide, because you discussed the same situation in the nmCRPC setting. You rather go for abiraterone than for enzalutamide when you have somebody with a neurological disorder. So side effects is an issue where you have to compare the three drugs. and probably also the discussion of later sequencing. I think Professor Tombal will cover the PSFS2 data from the Spartan trial, where there is some evidence or some hypothesis generated that abiraterone may work after apalutamide. So if you give apalutamide, you have another option in the M1-CRPC sequence, which you don't have when you start your sequencing with enzalutamide. So these may be considerations, but clearly it's the simplest way when you have like M1 disease in the one imaging modality and M0 in the other to prescribe the enzalutamide.
And another provocative question goes in the other direction. Seeing the better side effect profile of darolutamide, should we not only use this drug instead of apalutamide and enzalutamide?
Definitely. I mean, I think if you come like in the chronological order, I mean, enzalutamide is on the market for a decade, so everybody has experience with the drug, and I think urologists or oncologists are kind of reluctant to test new drugs when they have familiar drugs on the market. So everybody has to collect his experience with apalutamide. Somebody may say, okay, I have this rush issue, I don't want it, my patients are concerned by that, and this may be an argument for darolutamide, definitely. But it's not fair to say, based on the trial, you cannot one-to-one compare to them. I think everybody has to collect his own experience by using the drugs. And
one last quick question. The Fendler study you were just mentioning, they used already also Gleason score 8 and higher as a selection criteria. Obviously, that is not something you would consider for this treatment decision making to select patients for this treatment. It's just PSA doubling time and negative conventional imaging. That answers another question. What kind of imaging should we use if we are not supposed to use PSMA? Indeed, it's based on CT and bone scintigraphy, and there should be non-metastatic. So other information than PSA and conventional imaging is not what you would use for selection of patients for this treatment type.
So you're asking whether the Gleason score should be considered as well. Actually, I wouldn't say it, because it's not like has been predefined in the trials. We don't have a recommendation or the definition for that. I think if you have a biopsy Gleason on a, let's say, radiated patient 4 years ago, is this still characterizing my tumor? If initially had a 3+4 cancer and now he's castration resistant and he's progressing, I wouldn't say so. So I think now we are dealing with a systemic disease. So I think the initial PSA, the initial Gleason grade, which was taken in a still localized disease, probably maybe not representative of the current state of the disease.
Very good. And obviously it was not used as a selection criteria for the studies that are published. So obviously that would be something to extrapolate and would not make a lot of scientific sense.
That's it.
Based on this. Very good. Thank you very much, Thomas. Very nice discussion, nice presentation. We will now go to Bertrand Tombal, who will answer the question how we should follow up these patients and when we should switch the treatment. So obviously know now how to select those patients. We now know what kind of treatment we might offer to these. And once they are on treatment, Bertrand will tell us how we should go forward with those patients. Bertrand, please.
Hi, hello. Can you hear me?
You can, yes.
So I'm gonna move my screen. Okay. Okay, do you see my presentation? It's okay?
We can see it, yes.
Okay, perfect. So thank you for inviting me. So basically, we're gonna speak of what should we do and what's happening once the patient is on one of these 3 drugs. Here are my conflict of interest. I've been participating to trial with all the companies. So please, this representation reflect my personal view, and I try to make an equal use of apalutamide, enzalutamide, and darolutamide in the presentation. So don't be mistaken. So this is basically where we're starting from. So that's a 71-year-old patient who actually was started on external beam radiation therapy plus ADT. Actually, he was supposed to have 2 years of ADT, but as you can see here, didn't make it, start to have a rise in PSA. He had repetitive conventional imaging that were negative, was not treated because the PSA doubling time was quite long. And then here suddenly has a rapid PSA doubling time. So based on the new conventional imaging that was negative and based on EAU guidelines, as mentioned by Thomas, we started the patient on apalutamide. So it's very funny because in the urological community, it starts to be like, oh, that's complicated. These drugs are very, enzalutamide, apalutamide, darolutamide, oh, that's for medical oncologists and blah, blah, blah. No. I mean, just remember that 5 years ago, you would just have give bicalutamide to that patient. It's got the same name. The main difference is that it's much cheaper and less efficient, but in terms of management, it's very similar to what most of us urologists have been doing for the last 20 years by adding bicalutamide 50. So the question are, how do we follow these patients? When we used to give bicalutamide, we would just do the PSA. Do we do any imaging at what time, which generation? And very important, because I think we don't speak a lot about that. What about the management and prevention of side effect? That's something very important if you decide to put that patient on apalutamide or enzalutamide or darolutamide. And if you ask me why I choose apalutamide in that patient, it's because it's actually one of the first patients that enter a medical need program in Belgium because the drug was not yet reimbursed at that time. So many times what people do, and I believe it's a mistake, I'm going to speak a little bit about mistakes in this presentation, is that you go back and you see what we do during clinical trial. And keep in mind that clinical trial is a totally different setting. In clinical trial, you are optimizing the follow-up of your patient for defining the endpoint, MSF, PFS, toxicity. So you've got quite regular physical examination, PSA, imaging, quality of life. This is mostly for assessing the efficacy of the drug, and this is usually very similar in between the trial. And those of you who participate to clinical trial, we know we've got that huge skeletal sheet where we repeat a lot of exam. It doesn't mean that you have to do the same once you are in the clinic. So let's start by the basis. The basis is the PSA. And actually, what is recommended in the trial and actually can be kept is that we basically do a PSA after one month because that's a moment we would like to see the patient again, be sure everything is going well. And then we just do a PSA every 3 to 4 months. No more than that, like we did before for bicalutamide and other drugs. That's the beauty of these 3 drugs. You don't have like a monthly regimen like you have with AbbVie or other drug. You can really come on in what I call a standard urology pace to see the patient every 3 months and start with the PSA. So let's take for granted that we start with the PSA. So then, do you have to do imaging all the time? Do you have to repeat imaging every 3 to 4 months, 16 weeks, as recommended in the clinical trial? That is an extremely difficult question. And actually, if you look at the trial themselves, and here I take the example of the Aramis trial with darolutamide, and you look in the placebo group, you have here on your right the PSA progression and the radiographic progression. You see there is a disconnection in the placebo group that actually your PSA can keep rising and still without PSA progression. But actually, if you look at in the active arm, in the darolutamide arm, you see that the difference between PSA progression and radiographic progression on the median is something like 3 months. So that would say, let's be careful. Maybe that there is the possibility that progression may actually happen rapidly. And there are patients who may develop radiographic progression without having any PSA rise. That may be a minority, but actually is something that may happen. There's been additional studies. This is a very nice paper by Fred Saad on the PROSPER trial, so the enzalutamide trial that he published in European Urology last December, where actually they look at patients with and without PSA progression and look at the MFS. And you see that indeed there is some MFS, some development of metastases in patients without progression, but that is not huge in comparison to patients with PSA progression, where usually very rapidly MFS will develop, so meaning metastases will develop. So what can we take from this? It is extremely difficult, and I'm a kind of a, I don't like to impose too many exams to my patient. But to be honest, in that population, which is a high-risk population, it is absolutely uncertain whether PSA-only follow-up can be recommended. I still believe that regular imaging is recommended, maybe not every 3 months. I would maybe do it every 6 months, but monitoring the patient on PSA only is not to be recommended. And more important, I think that any rise in PSA should trigger an imaging, because there is a disconnection in these patients between the PSA progression. You may have subtle change in PSA and rapid progression on the imaging. And then, exactly like you discussed with Dr. Stober before, what imaging? Do you do standard, PET, whole body MRI? That's interesting, because this is kind of a theoretical discussion. Because actually, if you look at consensus, and this is a whole consensus, this is actually the second APCC consensus conference in 2017. We asked the question in nmCRPC, 74%, what kind of imaging would you use in non-metastatic CRPC? And actually, 74% of the subset of panelists voted for one of the next generation imaging methods to confirm this diagnostic. 48% for PET-CT, 6% for whole body MRI, 18% for a combination. So it answers a little bit your question before, that actually we do both PET-CT and whole body MRI in our center since 2017, and actually they basically give you the same result. It's later on in the disease when you're becoming super castration resistant, like in the VISION trial, that you start seeing patients with a PSMA negative lesion. So people do it already. We studied that. So actually in 2007 already, we showed that with axial skeleton MRI, if you take a population of patients with rising hormone naive or resistant, as such as high risk, actually, if your bone scan is positive, it is positive. But if you've got an equivocal bone scan or a negative bone scan, up to 30% of the patient will have metastases. So really, it depends what you want to do. If you want to find metastases, these new imaging technology will do. I just have a word of caution. It is not to repeat the PET PSMA too rapidly after starting apalutamide, enzalutamide, or darolutamide, because the existence of a flare, meaning a pseudo progression on PSMA that actually disappear after, it's not absolutely clear. We have seen patients with flare on PET PSMA. So the only recommendation is that if you monitor these patients with PET PSMA, don't do it too quickly. Don't do it after 3 months, just to be sure there is a response, because you started the patient with a negative imaging, positive PET PSMA. Some people told me, we would like to confirm that what we saw on the PET PSMA was a metastasis. It's not a good idea to do too rapidly the PET PSMA. But in conclusion, it's always the same discussion. We had a very nice meeting organized by Wim Ooyen and Stefano Fanti from the European Association of Nuclear Medicine. It was in Valencia in 2018, and the conclusion was simple. If you want to see more metastases, you ask your imager to do an MRI or a PET-CT. But these people will not tell you what to do with the result. So unless we design proper trial to measure the benefit of that imaging, we just know we're going to see more. but the impact on the patient has not yet been established. So it is important to know that actually, if you go back to the EAU guideline, unless you have some doubt, unless you've got eventually the intention of changing the treatment, be aware that just by doing new imaging technology, you're going to see more metastases. Very important, because basically the PSA monitoring is very easy. How do you monitor this patient? What is important in terms of follow-up of side effect? That's where you can't go to the guidelines, to the publication, excuse me. So if you look at the publication, the first observation will be that what is actually driving most of the toxicity is the androgen deprivation therapy itself. It is the effect of adding APA, DARO, or ENZA is very modest. You've got some increase in side effect, but it remains, after all, limited to grade 1, grade 2, and modest. And for each of the drug, you have side effect of interest. For apalutamide, this is fatigue, hypertension, fall, rash, and hypothyroidism that was actually described very early and seems to be carry on. With enzalutamide, this is mostly fatigue, hypertension, and fall. And for darolutamide, it seems indeed that the side effect seems to be less important, although it is interesting, and nobody has a fair explanation for this, that the rate of complication in the placebo group seems also to be lower. So I know, and you had this discussion, and it was very, I was thinking about what to tell you when you discuss what about the side effect of darolutamide. Is it really so good that we should actually put that drug first? You know, a word of caution, and actually that word of caution doesn't come from me. It comes from a very nice publication in Journal of National Cancer Institute in 2020 by the group of Phil Kantoff. And actually, they remind you something important. The important thing is that when you look in table in publication, you usually don't report the confidence interval for the frequency of side effect. When you report PFS, OS, MFS, it's always the median plus the confidence interval. In reporting side effect, this is always crude data. The 95 interval is not reported. And actually, if you report the 95% confidence interval that you can find in file like the FDA submission, it says that statistically speaking, you cannot draw any solid interpretation about the different side effect. And the conclusion they say is very important. Few clinically useful insight into OAE profile compare can be gained from the main publication, precluding meaningful complication. There are considerable variation in the absolute risk of EAs, even between placebo arm of comparable trial. So we have to be careful. Anyway, from this paper, we can isolate 3 countermeasures that should be applied by any urologist. The first one is to buy a stethoscope and a tensiometer and monitor blood pressure to the patient every time you see the patient, or even better, asking to buy a small home monitor and come with the blood pressure data. You have to put in place fatigue limitation measure. We will not speak about that today. It's mostly exercise. And very important, you have to think about bone health. If you want a very good paper on the risk of cardiovascular toxicity in these 3 trials, I will send you back to a very nice paper by Alicia Morgan in European Oncology, where she comes with the concept of ABCDE, which is awareness, blood pressure, cholesterol monitoring, cigarette smoking cessation, looking at diet, diabetes, and exercise. And these are really the 5 pillars of making your patient as happy as he can with limited number of CV toxicity the longest that you can. Because keep in mind that some of these patients will remain 3, 4, even 5 years on therapy. So we are gone to a very long period of time. And then bone health. That is extremely important. There's been a lot of discussion in the literature. We are not speaking about skeletal related even. we are speaking about osteoporotic fracture. These probably are not aggravated too much by apalutamide and enzalutamide, but at first are an ongoing process from ADT. But when you put somebody on APA and Zadaro, you're also extending the duration of the treatment with ADT. So this is very important to realize that you can have up to 10% fracture. Something we have also shown in a study with EORTC in a different study, which is the Peace Tree trial, where we find up to 10% of the patient having fracture on enzalutamide alone. So this is very important. Once again, this is primary care medicine done simply by any urologist following a patient not on APA, ENZA, ABI, or whatever, on ADT. You can, according to guidelines, I like to use the FRAC score because it's very easy to use. You can recommend from time to time a DEXA scan. You can find precise information in guidelines and in the literature. And actually, you can use that to decide who should receive bone treatment, bone targeting agent. And once again, here there is a confusion. I'm not speaking about giving high-dose zoledronate or high-dose denosumab to these patients. This is only for the metastatic castration resistant. I'm speaking about prescribing calcium, vitamin D, eventually denosumab low dose, 60 milligram every 6 months, which is the only one having shown to reduce the risk of fracture in patient on ADT. So that's so important because once again, we are speaking about 1 patient out of 10 that can present with an osteoporotic fracture, and that's a shame. So that is for the monitoring. So assuming we do exactly what we said, we recommend the patient some exercise, he's on vitamin D, he had a DEXA scan, he has his PSA done, and then here you start, that the PSA start rising. Once again, when do we declare a significant PSA rise? Does a PSA that goes from 1 to 1.1 a significant rise? No, there are definitions for this. And actually, you can go back to the prostate cancer working group 2 criteria and actually see that, first of all, the PSA needs to go down. If there is a progression of PSA above by baseline, that's a failure of treatment. That's important. And then you refer to nadir and you follow. So as I mentioned already, this is very important to image the patient. So here I did negative bone scan, and then we have a CT, and the CT actually show 2 lymph nodes increasing from 11 millimeter to 20 millimeter along the aorta. So be careful. That is the limitation of MFS. MFS, metastasis-free survival, that was actually used in the publication, does not mean you have to change the treatment. Once again, it's an endpoint that was an agreement between the company, the FDA, and the MA to define the efficacy of the drug. And MFS had its own limitation. The first limitation, first of all, is that the trigger to define MFS is much looser on lymph node than on bones. On bones, you just need an increase in more than 20% in size. So if you have a lymph node that was 20 millimeters going to 30 millimeters, 1 lymph node would be progression, where actually most urologists would say, okay, the guy doesn't have bone metastasis yet, so it's not a real progression. I'm not going to change my treatment yet. Where on the bone, you need to have 1 more lesion. That's very important. And if you have a single one, you need to have a confirmation. So it is important. And actually, when you look at the MFS in the trial, you see that 1/3 of these patients actually had only progression in the distant node. So that's important. Not all the progression are equal. Not all the MFS are equal. So although that patient would have been out of the trial, would have been counted as an MFS endpoint, it didn't mean it was time to change the treatment. That is very important. So clearly, you need here, when you decide to change a treatment, you need to apply something very important, which is your clinical census. And first of all, keep in mind that a PSA progression alone is not enough to change. That is very important. You need at least two criteria: PSA progression, clear bone scan progression, clear CT progression, and clinical deterioration. The problem is that what does it mean, a clear CT, clear bone scan? So it's still unclear. So once again, you need to apply. And my recommendation is, please don't change too fast. No, if you started the patient with a PSA at 10, the PSA is 12, he's got new bone scan lesion, you don't need to be a genius to understand your treatment is not working. But please, when your patient are on one of these three drugs, apply clinical sense, repeat the imaging, and confirm the progression. So what kind of imaging? So once again, if you use PSMA, PET, or whole body MRI, you need really to be confronted with very small oligometastatic progression while on apalutamide. So that's very difficult. Does it mean that this patient is not profiting from apalutamide yet? He's got a rise in PSA, he's got one single bone lesion. That is a very interesting topic for this patient. And actually, it was very interesting that when we discussed that, sorry, I forgot the reference, this is the APCC 2019, when we discussed patient with oligoprogressive metastatic chemotherapy naive CRPC. So this is this kind of patient. I mean, many people, actually 46% of the physician, I think Thomas, you were one of these, we did recommend it actually to go for metastatic targeted therapy in this patient, not immediately to switch. No, unfortunately, they will not last forever. At some point, the patient will come, rapid rise in PSA, progression in bone scan. This is what we call an unequivocal progression. No, it is time. You need to change the treatment. So what do you do? I heard that, you could be tempted. He was on APA. I'm going to give a little bit Enza, a little bit Daro, a little bit of Abi. I could give docetaxel. I will not speak about DDR alteration and PSA lutetium. I guess this is for future. And I'm going to speak, not going to speak about radium because we are out of the EMA label. So what do you do between docetaxel and adding a line of back-to-back ARTA? Actually, once again, be careful about the trial. If you read the trial, you see that actually abiraterone was one of the most recommended treatment in the 3 trial. But please keep in mind, this was a placebo-controlled trial. So an unblinding was not allowed. So that when the patient was progressing, the physician didn't know whether he was on APA, Enza, Daro, or a placebo. And that changed the whole game. And based on this, we know that abiraterone after enzalutamide, there are several trials now. There are randomized trials. There is very little change of response. And then there is what I call a misuse of PFS2. Many times I hear, yeah, PFS2 means there is a response to abiraterone after apalutamide. Actually, we don't know that. To my knowledge, the PSA response have never been published. We've never seen that. The PFS2 doesn't mean that you can add ABI or switch to ABI after. It just means that if you delay the treatment in a patient with a high-risk non-metastatic CRPC, you will never catch up. That's the correct interpretation. So be careful. So clearly, in that setting, the reference treatment remained docetaxel. Whether it's abiraterone or enzalutamide, they have nice PSA response rate. They have been published. So clearly, that's the reference. So clearly, I believe that the best option now in a patient that is fit for is to start docetaxel. Back-to-back ARTA, my personal view on this, it's a waste of time, waste of money, response rate, and unless we have trial really demonstrated that it's working, the global understanding is that the effect is very, very limited. And in the future, that's where we're going to discuss more sexy alternatives such as PSMA lutetium and PARP inhibitor. So in conclusion, for the follow-up, physical, PSA, and complete lab every 3-4 months. I believe regular imaging is recommended every 3 to 6 months, and especially any rise in PSA should trigger imaging. The impact of new imaging technology is yet to be determined. Overall, the side effect profile is very similar for the 3 drug. It means you should monitor blood pressure, consolidate fatigue limitation measure, and manage bone health. As for change of therapy, please keep in mind that MFS is a regulatory endpoint based on conventional imaging. Reaching MFS doesn't mean the treatment should be stopped. An isolated PSA rise is insufficient to trigger treatment change. It must be associated with clinically significant radiographic progression or symptomatic deterioration. Oligometastatic progression based on new imaging technology may eventually trigger metastatic directed therapy. Docetaxel is the standard third-line treatment, but emerging alternatives are on the horizon, and I really believe that back-to-back ARTA is not supported by evidence. Thank you very much for your attention.
Thank you very much, Bertrand, for this excellent presentation. We have a few more minutes left, some quick questions. Many of those who are on the Q&A box are already answered by your presentation, so I would not think that we would need to go back to these. One question is addressing the sensitivity of PSMA and how the sensitivity of PSMA might change during treatment. Do you have any information about that? If the hormone manipulation does change anything of the PSMA expression?
Actually, the only thing we know is about the initial flare, where there is some literature. We just completed a study where we were comparing PSMA and whole body MRI for the follow-up of the patient. So not that setting, patient and on metastatic castration resistant, and it's absolutely not clear. So first of all, there is a lot of heterogeneity for both techniques. So you see a lot of patients. There's more heterogeneity in each patient individually that between the techniques. So that's something we still need more data because it's not clear. Once again, the only exception is not to do the PET PSMA immediately right after changing the treatment, because there it's been shown they have variation.
Indeed, it is an unknown field how the PSMA or maybe also choline or FDG might change under treatment, and if those flare phenomena are a good sign for a patient or a sign of good response or bad response. But obviously there's a lot of potential behind it to check early if those drugs are effective for a patient or not. Another question I would have, you said you should do regular imaging in those patients, and in a 3 to 6 month period or schedule. Would your frequency depend a little bit on how the disease behaved before it become castrate resistant? In other words, somebody who is progressing rapidly after local treatment, for example, would you do here an early or more frequent imaging, or somebody who is like 4 or 5 years out for local treatment and then become castrate resistant? There you would think you might have a little bit more space or time between the different imaging exams. Does this influence your schedule?
Not really. What influenced my schedule, and we didn't have time to discuss, is really the PSA response rate. Because the magic of AR-targeted therapy and PSA is that PSA, with all its limitation, is a beautiful prognostic factor if you look 3 to 6 months. So many people start to investigate like the value of the PSA at 1 month and 3 months. And indeed, in a patient that would start with a PSA of 5 and the PSA goes down to 2, I would repeat imaging more rapidly than in somebody who start from 25 and go to 0.1. One of the observations we have made is that we have many patients, including those we put in the trial, who actually had their best PSA ever the day they started the treatment. So we have patients like this who had prostatectomy, radiotherapy, ADT, never normalized their PSA. And then you put them on one of these drugs, it goes to undetectable. So I think that there are more and more data. And in order, in order to decide in who you can postpone. First of all, I would never postpone the first exam after 3 months. And thereafter, I would look primarily at the amplitude of the PSA response.
Okay, very clear. There are other blood-based biomarkers used for metastatic prostate cancer, such as hemoglobin, alkaline phosphatase, or LDH, or albumin.
Yeah, I told all my residents that you have to use what I call the cheap combo. Meaning everybody who is castration resistant should get PSA, alkaline phosphatase, hemoglobin, LDH. That's the minimum. Everybody say, what about testosterone? I mean, if the guy has been on Leuprolin for, it won't come back like this. So we've got occasional patients who forget their agonist. Then we measure testosterone, but you have to measure this. And I mean, alkaline phosphatase, that's a beautiful marker. If it starts to rise very rapidly, your patient has bone metastasis. That is as simple as that. So that is the minimal combo. And on top of that, fasting glucose, cholesterol, and lipid profile. That's the basis. That's in most European countries not more than 30 euro. So that's very cheap.
And these might then also trigger a new imaging if ever you have changes in these blood markers.
Exactly, especially in alkaline phosphatase.
Okay, very good. And one last question for the kind of imaging that you do. Would you say that for regular follow-up, like these standard imaging exams, you would go for conventional imaging, and maybe for coarse imaging, if you have rising markers, you would go for more sophisticated imaging such as PSMA?
Yes, exactly.
For conventional imaging.
Once again, when I've got a patient with a stable PSA, he's happy, he's 75 years old. I don't want to put him in all the trouble of changing everything. So I use a very low sensitivity trigger, like bone scan, CT scan. And then if I've got a young patient with a rapid PSA after initiation of the treatment, then I really want to know what's happening. And then, these imaging, they're going to give you an answer. So if you don't want to find anything, don't use them. If you want to find something, use them. That's easy as that. But never hope that the imaging people will tell you what to do with the result they give you. That's clear. They said it themselves.
And always use your clinical judgment in addition, and make the combination out of all the information that you get to decide the right thing for the patient. Thank you very much, Bertrand, for this excellent discussion. So
you're welcome.
To wrap it up, we heard first from Thomas Stoiber that the PSA doubling time needs true calculations. So it's not eyeballing, but you should use the logarithm that goes with it, and the system, the algorithm that goes with it. And indeed, internet-based tools are very helpful here. Lower the PSA doubling time, the higher the likelihood of having metastatic disease or developing metastatic disease in the future. So these are the high-risk patients. The use of imaging in this situation is relative. The more sensitive your imaging, the higher the likelihood you will find metastatic disease, but it would not be recommended in this setting where conventional imaging is the standard and helps you then to select those patients who are candidates for a treatment with enzalutamide, apalutamide, or darolutamide. And to pick between these three drugs, you would leave it to your personal preference, the experience that you have, the preference of the patient, the side effects, and of course also the reimbursement situation in your specific country. Once the patient are on the treatment, the follow-up, of course, is very important, which is a combination of PSA, other blood markers, as we just heard, and imaging at the very beginning at 3 months, and then you would go on with the PSA physical exam and the blood markers every 3 months, and then the imaging every 3 to 6 months, depending very much on what the development is of the disease. And then, of course, during follow-up, it is essential, and the key point here, to manage the side effects and to check for side effects and to maintain bone health in your patients. And when should you change your treatment? When would you say that the treatments are not more effective anymore? Do not change treatment only on a PSA rise alone. You would need at least 2 out of 3 of the following criteria: a rising PSA, changes in the imaging, no matter if it's on the CT or on the bone scintigraphy, or if the patient develops symptoms. And if you have 2 out of these 3 criteria, you would change the treatment and consider then in the following probably chemotherapy if the patient is fit for this. With this, I would like to thank you very much for participating and joining us for this webinar. I would like to thank very much Bertrand Tombal and Thomas Stoiber for their excellent presentations and discussions. I hope you enjoyed it very much, and I'm pretty sure that we will see each other very soon at the annual meeting of the EAU early in July. And have a nice evening, and maybe you enjoy also the Euro Cup. There are some nice games to come up. Thank you very much. See you soon. Bye-bye.
Bye-bye. Thank you.